forward. It doesn't look like it's needed. Good morning, everyone. This is Dr. Fondon. I'm going to introduce Dr. Megan White for her grand rounds this morning.
Dr. White is initially from St. Louis. She went to Truman University for undergrad, and then she went to St. Louis University for medical school, where she excelled. While she's been here, she has been very active in community outreach and engagement, which is something that she also was interested in during medical school. She has also been very active in research and is going to talk about some of her research findings today. So Megan, you can come up and get started.
All right, thank you, Dr. Fondon. So today I'm going to talk about non-alcoholic fatty liver disease. And this is a topic that I've been doing some of my research in for the last about year and a half. And the reason I'm giving this talk is because, I've noticed through my research and just through looking through the other research that's been done is this disease is not very well understood, and this disease is not very well noted in the primary care practices. So I hope by the end of this talk that you understand what non-alcoholic fatty liver disease is, and as well as understand the importance of it and why you should be looking out for this in your patients. I have no financial disclosures. In a quick outline, I'm just going to go through the historical context, what is NAFLD and NASH, the epidemiology, impact, diagnosis and treatment, and future directions. So just to start us off, I wanted to give a quick clinical vignette. And this was actually a patient that I had in the ICU after I was okay. Did you want me to start back over? Can you hear me now? Oh. Okay. You can hear through Zoom. Okay. All right. So just to give a quick clinical vignette about why I'm talking to you about non-alcoholic fatty liver disease. This is a patient I had in the ICU actually after I was asked to give this grand rounds talk, and it kind of encompasses why I'm giving it. So this is a 64-year-old woman. She has a history of breast cancer that's in remission, hypertension, obesity, and recently diagnosed with NASH cirrhosis within the last week. She presented from the outside hospital for shock and liver failure, and she ended up dying from complications likely of septic shock 3 days. We still don't have sound. Oh gosh. Okay. All right, I'll let you fix that.
Okay.
All right, can you hear me on Zoom? No, okay. Do you want me just to use this microphone then? Okay, now can you hear me on Zoom? You can hear me on Zoom, okay. All right, well, thank you again, Dr. Fondon, for the introductions. And today, sorry about the technical difficulties, but we're going to talk about non-alcoholic fatty liver disease. This is something that I've been studying for the last about year and a half here. And I feel that it's very important because I think it's very poorly recognized and very clinically impactful. And so I hope by the end of this talk, you can realize how this disease may impact your patients and what you need to do to look for it. I have no financial disclosures and a quick outline. I'm going to go through the historical context, what is NAFLD and NASH, the epidemiology, clinical impacts, diagnosis and treatment, and kind of the future directions. So just to go over a quick clinical vignette, which kind of encompasses why I'm giving this talk. This was a patient of mine in the ICU that I actually had after I was asked to give the Grand Rounds talk. So this is a 64-year-old. She has a history of breast cancer, hypertension, and obesity. In the last week, she's been diagnosed with NASH cirrhosis, and she presented from an outside hospital for shock and liver failure. She ended up dying a couple days into her admission, likely from septic shock. Interestingly, she had about 2 years of vague complaints of ascites, lower extremity edema, and fatigue. She was also told by her doctor that some of her liver enzymes were off, yet it took about 2 years for her to get sent to the hepatologist at WashU. Her daughter asked me after her mom passed, she said both her mom died of NASH cirrhosis and, interestingly, her grandmother died of NASH cirrhosis, and she wanted to know how she could prevent NASH and how she could monitor it with her doctor. So I want you to keep that in your mind as we go through this presentation. So just to give you a little bit of historic context, we've known about fat in the liver for literally thousands of years. There are hieroglyphics going back to 2000 BC that show the Egyptians force-feeding geese for what we now refer to as foie gras. But in modern history, we started noticing it first in the late 1700s, and there was a report noted on diabetic cadavers, and many of these diabetic cadavers had fatty infiltrate in their livers. But it wasn't really until the 1900s when we first started putting this into our modern literature. So first noted hepatitis of fatty liver in 1962, but it was 1980 when Dr. Ludwig actually named this entity non-alcoholic steatohepatitis that it started having clinical impact, and studies started around a decade later when people actually started paying attention to NASH and NAFLD. And then again in 2002 when we renamed this entity NAFLD, and I'll get into the reasons behind that in the next slide. Just interestingly, I wanted to point out, we've known about alcohol being linked to cirrhosis since about the 1920s. Hepatitis B was discovered in 1960, and hepatitis C was discovered in 1988. So hepatitis C was actually discovered 8 years after NASH was named, which I think is really interesting because in our primary care clinic, everybody screens for hepatitis C, and we have now a cure for that. So you can kind of see the differences in how these two disease entities have been treated. So what is NAFLD? Non-alcoholic fatty liver disease is hepatic steatosis, encompassing at least 5% of the hepatic sites, and it has an exclusion of all secondary causes right now. So that means that any heavy alcohol use, viral hepatitis, Wilson's disease, autoimmune diseases have to be excluded for you to call this NAFLD. And you can diagnose this on either a biopsy or imaging. And you can kind of see here, if you can see my pointer, this slide here would be our fatty liver where you have the steatosis in the liver cells. NASH, however, is steatosis plus inflammation and hepatocyte injury. So that is the differentiating factor here. They've seen this as hepatocyte ballooning and inflammation with neutrophil coming in. On the second picture here, you also see fibrosis within our NASH patient on this biopsy. You do not have to have fibrosis to have NASH, but you do have to have hepatocyte injury. And so technically this does require a biopsy, but we have many other non-invasive ways of looking at fibrosis in NASH. So just to go along with the pathogenesis, this is a very busy slide, so I'll go through it pretty briefly, but essentially what NAFLD and NASH is it's too much free fatty acid coming into the liver. And so that encompasses the entire pathogenesis of this disease. But what we really need to pay attention to is our adipocytes. So especially in NAFLD and NASH, you get insulin resistant in the hepatocytes of these patients. And essentially what that does is it increases lipolysis and increases serum free fatty acids that then go through the liver, and it's the liver job to package those up. So we start pretty much with these adipose tissue, and this is going to be different for every different patient, how much adipose tissue it takes, and also with insulin resistance. But once you get the free fatty acid into the liver, the job of the liver is to get rid of it. And it does this through a couple different ways. First, it packages it through the VLDL, and then it also gets rid of it through beta oxidation. But when those get overrun by the sheer amount of free fatty acids, you end up getting triglycerides being deposited in the liver, and that's what we call NAFLD. And then to go further with that, when they start becoming toxic, those triglycerides and lipid depositions, that's when you start getting NASH. And there's a lot of other things to think about here. Certainly a lot of genetic factors that go into this, dietary factors, which makes sense with the free fatty acid, and the gut microbiome, which with increased permeability can release substances that will cause inflammation and apoptosis in these patients. So this is a nice slide just detailing how important NAFLD is worldwide. So I want to first point you out to the United States. We're here in red, dark red as usual, which puts us at greater than 30% of our adult population has NAFLD, which is just a huge amount of patients. To put that in context, about 11% of patients here have diabetes. So this is a huge amount of patients with NAFLD in the United States. And if you look over to the side, you can see that it's actually more prevalent in our Hispanic American population, and it's the least prevalent in our African American population. And this is thought to be due to some genetic causes. If you look at the rest of the world, we're talking about 25% of the rest of the world has NAFLD. So extremely prevalent throughout both the United States and the rest of the world. So how does that impact our patients? Again, NAFLD is thought to be more of a benign disease of just lipid deposition, and it's not until those lipids become toxic to the liver with inflammation and apoptosis that you really start getting fibrosis and cirrhosis that causes problems in our patients. However, that's not quite the whole story. Our patients with NAFLD, even with this, what people might call benign steatosis, they're at increased risk of diabetes if they do not already have that. And they're also at increased risk of cardiac diseases. So that's going to be the #1 morbidity and mortality of our NAFLD patients before they get to stages of advanced fibrosis. So despite the fact that you're not seeing any inflammation on the liver in these patients, they are still at increased risk for other morbidities and mortalities. And then talking about how many of these patients actually go on to have NASH and go on to have cirrhosis, about 20% of our NAFLD patients will end up having NASH. And then if you go from there, about 20 to 40% of our NAFLD patients end up getting cirrhosis. It is one of the leading causes of hepatocellular carcinoma in our advanced fibrosis and cirrhotic patients. And it's the second leading cause of liver transplants, but currently it's #1 in women and people over the age of 65. So this is incredibly impactful for our patients right now. And between 2004 and 2016, we actually saw a doubling of our transplant list just due to our NASH cirrhotic patients. So not only are we seeing an increase in transplant, but we're seeing an increase in waiting lists for these transplant patients as well for all of our liver failure patients due to the sheer numbers of our NASH patients that we're seeing. And just to give you a little understanding of how we progress through this, we're still coming out with a lot of epidemiological data. As you see, it's the 1990s when we started having a lot of research, but the thought is it's probably about 14 years to go from NAFLD to NASH, and then through each stage of NASH fibrosis, stage 0 up to 4, it's thought to be about 7 years, but that's doubled in our patients with hypertension. So about 3.5 years to progress through each stage. And that's pretty raw estimate given that we're still having a lot of epidemiological studies coming out. So where are we at now? I hope that you understand both the impact that they have in terms of sheer numbers and how it affects your health. But our primary care physicians, they're just not recognizing NAFLD and NASH. So in a couple studies that were done in the 2010s, you can see that about 1 to 5% of primary care physicians are actually recognizing NAFLD when we look back at their notes. So this is all through looking at notes. And even more concerning, there's a study in 2013 where 69% of primary care physicians said they did not think NAFLD was clinically important. It was only 7 years ago, and you can see that we're moving up to #1 on the liver transplant list, and yet many of our primary care physicians are not seeing how important NAFLD is in their patient populations. We did this study here at the Co. This is our resident-run primary care clinic,
And we saw about 10% of our NAFLD patients were actually recognized by their primary care provider. So we're better than the national average, but we still have a long way to go. And if you see the data I have in the lower corner, this is also from our research at the CO. And you can see that weight loss counseling was increased in these patients, which is exactly what needs to happen. However, their actual weight loss was not significantly different. So there's a big disconnect there with our patients. And the other things that we find very important in the treatment of NAFLD and NASH is getting your metabolic conditions under control. And you can see here that the A1C and the blood pressures were not significantly different between our recognized NAFLD patients and our unrecognized NAFLD patients. And in fact, our triglycerides were actually higher in our recognized NAFLD patients than our unrecognized NAFLD patients, which may be due to statin use, which we'll get into. So how do we diagnose this? Part of the problem in everything that I'm telling you about is there's no screening guidelines at all for NAFLD and NASH. So at this point, our diagnosis is essentially through seeing steatosis on imaging that's usually done for another reason. And so our options, ultrasound, CT, MRI, all make sense to you here. The MRI is going to be your gold standard, but as we know, it's expensive and time consuming. And then of course, when we're talking about NASH and NASH cirrhosis, a biopsy is going to be how we diagnose these patients. But just to give you a little information here, because this is something that I've noticed, you will see an ultrasound done last year that may say they have mild steatosis, and 2 years ago said nothing, and 6 months ago said nothing. So do they have steatosis or don't they have steatosis? And so our ultrasound is actually very poorly sensitive to our mildly steatotic patients. So you can see here at 5 to 9%, they're really not doing an excellent job of picking up steatosis on our ultrasound. And this is somewhat similar in our CT scans as well. But it is quite good at picking up moderate to severe steatosis. So just keep that in mind. If you have high clinical suspicion for a patient and you're not seeing it on ultrasound, you may want to choose a different imaging modality. As far as risk stratification, once you diagnose these patients, you see on imaging that they have steatosis, where do you go from there? And the important part about risk stratification is when to get them and to see a hepatologist. So we use our non-invasive screenings, our FIB-4, our NAFLD fibrosis scores. You can find these on any sort of medical calculator. They use things like your AST, ALT, platelets, age, BMI, whether or not you have diabetes, and they predict how much fibrosis a patient has. So this is not going to tell you whether or not they have NAFLD or NASH. That's going to be based on your own clinical diagnosis, but this is going to predict the degree of fibrosis. And so when you have a high degree of fibrosis, that's when you're talking about sending them to a hepatologist. You've also got elastography, which is an imaging modality. You can do it through MR or transient elastography that we have here, like the FibroScan. And again, that'll just tell you how much fibrosis a patient may have. The Dallas Steatosis Index Calculator, this was developed by Dr. McHenry here, and it helps predict which patients may or may not have NAFLD and NASH. And so that can be easily found by just Googling the DSI calculator here. As far as treatment, this is another big concern for NAFLD. Again, it's incredibly important, it's incredibly prevalent, but we have very, very little treatment for this, which is a big problem. So you can see at the beginning stages of NAFLD and NASH with no fibrosis, our cardiac issues is going to be one of the most important issues that you're going to want to pay attention to. And so really right here, you're going to be thinking about lifestyle interventions and comorbid conditions. So our lifestyle interventions will help us prevent the progression from NAFLD into NASH and into fibrosis. And then our comorbid treatments is going to help prevent what NAFLD causes, which is an increase in diabetes and cardiovascular risk factors. And so this is a weight loss. 5% we see a good job in helping with our NAFLD patients, but it takes about 7 to 10% in our NASH patients to really see a difference here. And as many of you know, treating patients, this is quite difficult to get a patient to lose 5 to 10% of their body weight. There's also, of course, bariatric surgery. However, right now, most insurance companies will not cover the cost of bariatric surgery for NAFLD and NASH alone. They do require you to hit another component that they will cover, given something like BMI or another comorbid condition like diabetes. Our treatment options right now are only vitamin E and pioglitazone. And many of these treatments are not used very much in our primary care clinics. Vitamin E shows an increased risk of morbidity and mortality overall. And so while it does show some regression of fibrosis in our patients, we don't have enough studies to see if they actually clinically do better over a long period of time. Same thing with our pioglitazone. While it does show regression in our fibrosis of our patients, it also increases cardiovascular death, which I just told you is one of the major causes of death in our patients with NAFLD and NASH. And it increases weight gain, which goes against what I was telling you about with lifestyle interventions. So these are not medications that we're actually using very routine. Vitamin E is sometimes used with our hepatologist, but pioglitazone is very rarely used unless for another indication. And I just want to quickly point out that statins can and should be used for your patients with NAFLD and NASH, especially if they meet criteria for having high cardiovascular risk factors. So this is a very important medication that I think sometimes that we think if they have liver disease, I can't use this, but this actually should be used in our NAFLD patients. So let's just jump back to the clinical vignette after everything that I've talked about. And I really don't have great answers for all of these things. So we'll go through them with my personal judgment, but again, the screening guidelines just aren't there for us right now. So first of all, should this patient, our 64-year-old that ended up passing in the ICU, should she have been sent to hepatology sooner? I can tell you right now, I did not have any of her records from her previous 2 years at her primary care physician, so I can't answer this completely. But what I can say is that likely she had elevated liver enzymes according to her daughter, as well as having ascites and lower extremity edema and fatigue. And so my guess is that with her steatosis, if you would have put her into the FIB-4 or you would have put her into the NAFLD fibrosis screening, she would have shown a intermediate or high likelihood of having fibrosis to be sent to our hepatologist sooner. Would this have made a difference? I certainly can't say that for sure. We know that our liver patients decompensate quickly, and how quickly she would have been able to get on the transplant list, I wouldn't be able to say. But certainly I think that it's likely that had her physician run some non-invasive screening, that maybe she could have seen a hepatologist sooner. How about the daughter? Should we screen the daughter? Right now, in the United States, the recommendation is not to screen family members of our NAFLD and NASH patients. So that is our current recommendation. I would say this though, is that you, as a primary care physician, should be looking out for any changes in her liver enzymes. And at the first sight of those changes, I would get an ultrasound on her and try to see if she has NAFLD or NASH and go from there. And then what can we tell this daughter about prevention? She was overweight, so that's the first thing that you're gonna wanna hit with her if she wants to avoid the fate of her mother and grandmother, to start losing weight now and make sure that she's being very diligently screened for diabetes, high blood pressure, and high cholesterol, which are all factors that we know can help in the outcomes of our NASH and NAFLD patients. So just to hit a few of the future considerations, you've got screening considerations, of course. In Europe, they're already recommending we screen patients that have metabolic syndromes, are overweight, over 50, as well as patients with family members with NASH and NAFLD. So that is actually a recommendation. And our European colleagues, it is not yet the recommendation here, but I think as we find more ways to easily diagnose this and ways to treat this, we're going to start seeing some changes in our own screening guidelines here and towards wanting to screen our patients just like we do for diabetics and cholesterol. The other interesting thing that came out in the last couple months is a renaming again of this entity to MAFLD, which is metabolic associated fatty liver disease. And the reason for this is twofold. One is that most hepatologists now believe that this can be diagnosed even if they have other things like alcohol use. If they have insulin resistance, if they're obese, if they meet all these other metabolic criteria, it's very likely that NAFLD is playing a role in their steatosis, even if they have other things such as alcohol use. And the other part of that is that obviously we're moving away from calling everything alcoholic. We move towards alcoholic associated, and there's just a lot of stigma when you put the word alcohol in a disease entity. So they're moving away from that. And then of course, lastly, we need new drugs, and there's quite a few new drugs in the pipeline for NAFLD and NASH patients. And so in an article published last year, they said that 2020 would be the year of NASH. We all know that that's obviously not the case. It's clearly the year of COVID, but there's a lot of drugs coming out, so just look forward to some of these things. And then I'll just end with a quick note on some of the drugs you can see here that are in phase 2 and 3 trials. Obeticholic acid is one of the ones that actually was fast tracking through to get approval, and they met all of the criteria that they had agreed upon with the FDA, and they still actually did not get approval, and they still wanted more data for this. So this was actually just turned down for approval a few months ago. But I think that with more data, you're going to see this become approved in the future, and you're going to see a lot of other medications become approved in the future. So with that, I want to thank all of my mentors, program director, Dr. Frazier, all the PGY3s. Appreciate all of you being here and listening to this presentation, and then there'll be questions at the end.
Good morning, everyone. My name is Kalin Matar, and I'm an assistant professor of medicine in the Division of Infectious Diseases, and I'm the director of the Global Health Pathway for Internal Medicine residents. I have the utmost pleasure today to be able to present Dr. Kevin Montes. Kevin grew up in Denton, Texas, and he went to undergrad at the University of Texas at Austin, and then at the University of Texas, Houston for medical school. Then we were very fortunate to recruit him here from the great state of Texas for internal medicine residency. I have known Kevin as a mentee and also as a resident in the Global Health Pathway, and I can certainly say that he's exemplary both in way of patient care as well as community engagement and research, where he's looking at tuberculosis in Guatemala, as well as different other projects here in the United States as well, and at WashU. I am hoping we'll also be very fortunate to recruit Kevin to stay with us for fellowship. He is interested in infectious diseases, critical care, global health, as well as history. He'll be talking to us today about climate change and infectious diseases, and I genuinely hope that his talk will stimulate all of us in healthcare and as healthcare providers to think about what is our role in fighting climate change.
Thank you for that introduction. Am I going through on Zoom right now? Can I be heard? Great, excellent. Thank you very much for that introduction. Excuse me. So I wanted to talk on climate change and infectious diseases, which are two things that I've been thinking a lot about recently. And the focus of this talk is going to be mostly how the former is going to be affecting the latter in the decades to come. So as far as some learning objectives, I want to go over the interconnectedness between the relationships between climate change, society, and infectious disease. I want to review some of the evidence for how climate change is going to make infectious diseases more prevalent, with a particular emphasis on vector and waterborne disease. I want to review how our relationship with our environment may have contributed to the initial spillover event that led to the current pandemic, and review how climate mitigation strategies can be affected by, pandemic mitigation strategies can be affected by climate change. And finally, I want to reflect on a past climate-related pandemic and its subsequent impact on world history. So to briefly go over some of the evidence for climate change, global temperatures have been going up by 1 degree Celsius since the onset of the Industrial Revolution and are projected to continue to increase in the decades to come. It's expected that there's going to be significant changes in patterns of precipitation, more intense tropical storms, more intense precipitation events in some areas, along with worsening drought and longer and worse heat waves in others. Global sea levels have been going up since the 1960s and are predicted to increase by up to more than 0.5 meters by the end of the century. And the World Health Organization predicts that in 30 years, there's going to be 250,000 more deaths because of malnutrition, malaria, diarrhea, and heat stress than otherwise would not have occurred without climate change. The IPCC, which is the Intergovernmental Panel on Climate Change, projects that the direct cost to health is going to be $2 to $4 billion annually. And those countries with the weakest health infrastructure are those that are going to be most strained to cope with the crisis. Here we can see that the world's temperature has been going up since the 19th century, and that the rate of increase in temperature has been going up in the last 25 and 50 years. And here on the left is a graph of projected temperatures over the next 300 years based on different models of predicted climate change. And we're going to refer to these a couple of times throughout this talk. Where's my cursor? There it is. So the A2 projection is a very severe projection as far as how well we control climate change, with the B1 being a more conservative projection. And as we can see over the next 300 years, pretty much uniformly, with the exception of the constant composition commitment, which may not be super realistic for us where we are right now, there's going to be significant increases in temperature worldwide. And on the right is a global map of change in annual mean precipitation according to the A1B model between 2080 and 2099. And what we can see is Central America, parts of South America, South Africa, and Australia, and the Mediterranean region are expected to have significant decreases in mean precipitation, while other areas like Alaska, part of the Northern Andes, and East Asia are going to have a significant increase in amount of precipitation. To discuss some of the more direct impacts of climate change on health, global food production is expected to decrease annually despite increases in demand, with an estimated 25 million more children expected to be undernourished because of the effects of climate change by 2050. One study found that the risk of conflict increases with increased rainfall and warmer temperatures, and dislocation either directly from climate change because of things like droughts, flooding, and heat waves, or indirectly because of conflict. This is all going to strain existing health systems. And all of these things, malnutrition, deterioration of existing health systems, and dislocation, can contribute to increasing infectious disease burden. But in the interest of time, we're going to focus specifically on vector and waterborne diseases. This figure illustrates the reciprocal relationships between changes in climate, society, and infectious diseases, which I think is useful to conceptualize how changes in one can affect the others. So, for example, the way we respond to changes in our environment, such as staying indoors more to avoid very hot or cold weather, can contribute to the spread of respiratory infections, or alternatively, decreased precipitation or drought can cause more people to concentrate around smaller areas and water supplies, which can promote the spread of vector and waterborne illnesses. On the left is an image from Milwaukee in the spring of 1993, where heavy spring rains led to significant flooding and a cryptosporidium outbreak, with the New England Journal estimating that 400,000 people were affected, which was at that time the largest ever documented outbreak of waterborne disease in the United States. And researchers have found that climate modeling projects that there's going to be a 50 to 120% increase in overflow events like these in the Great Lakes region of the United States by 2100. On the right is an image of Puerto Rico after Hurricane Hortense, where there was a 4-fold increase in cases of leptospirosis. And generally speaking, waterborne diseases are expected to worsen because of heavier precipitation and more intense tropical storms. More recently, the first ever cases of human leptospirosis were diagnosed in the US Virgin Islands in 2017 after hurricanes Irma and Maria. And climate change is going to make outbreaks like these more and more frequent. Cholera is already a significant cause of mortality worldwide, with an estimated 120,000 deaths attributed to it annually. The Vibrio cholera bacteria, the natural habitat for it is the brackish water or salt water, and rising sea levels are predicted to increase the amount of seawater that intrudes inland and can contaminate water supplies. And hotter and sunnier climate will favor the replication of the phytobacteria, which is a reservoir for cholera with which it has a commensal relationship. And the expansion of these phytoplankton populations is associated with epidemics. Additionally, increasing temperatures can lead to both the expansion geographically and temporally of cholera, meaning that a greater portion of the year is going to be at risk for epidemics. There was a study from researchers in Tanzania which found that an increase in temperature of 1 degree Celsius led to a 30% increase in the risk of cholera, and that they predicted that the increase in attributable to climate change is going to cost Tanzania up to 1.4% of its total GDP by 2030, which highlights how those countries with the fewest amount of resources are the ones most exposed to the negative health and economic consequences of climate change. This is a study where researchers modeled the suitability for cholera in a variety of environments and projected its distribution based on the body of water's mean projected density of chlorophyll A, dissolved oxygen, pH, sea surface temperature, and salinity. And on the left, you can see red are more suitable environments, and the kind of paler tan color is a less suitable environment. And what they projected according to the B1, so remember a fairly conservative model for how climate change plays out, is that there's going to be a general increase in suitability for cholera moving towards the poles, and this reflects the polar shift of the phytoplankton population. But additionally, we can see that there's some restriction in its suitability in equatorial regions, which might be related to increasing temperatures, making it less attractive for the cholera bacteria. Vector-borne diseases are also going to be incredibly important moving forward. The dynamics between climate change and the spread of vector-borne diseases are incredibly complex. So they're generally transmitted by arthropods, which are ectothermic, so they derive their internal temperature from the external environment. And arthropod larvae generally require specific conditions for appropriate development. So they need just the right amount of body of water to lay their eggs, and also very specific humidity conditions. Researchers have found that the vector biting rates and extrinsic incubation period, which refers to the amount of time it takes from acquisition of an infectious agent by a vector to the time that the vector can transmit the pathogen, both of these things increase with temperature. And if the effects of climate change aren't mitigated, the transmission season and geographic range of many of the vectors is going to expand significantly. This is a model which was designed to predict how West Nile virus would respond to climate change, which I only include in this slide just to show how incredibly complex these relationships are. And it also demonstrates how changes in temperature, precipitation, humidity, et cetera, aren't necessarily linear. A very significant disease that's going to be affected by climate change is going to be malaria, which is already a massive public health problem. In 2018, there were 228 million cases with an estimated 400,000 deaths. And it's caused by 5 species of the Plasmodium parasite and transmitted by the Anopheles mosquito. Both the Anopheles mosquito and the Plasmodium parasite have very specific conditions to develop appropriately. So for example, the Anopheles mosquito, as I mentioned before, needs just enough groundwater to collect in pools, but not so much that the pools wash away and wash away the larvae, but it also has to be just enough such that the pools don't evaporate. And the Plasmodium parasite requires a minimum temperature in the air to replicate within the mosquito, so about 15 degrees Celsius for the Plasmodium vivax and about 20 degrees Celsius for Plasmodium falciparum. Plasmodium falciparum infections have been increasing around the globe, and as a reminder, Plasmodium falciparum is the more severe form of malaria. And researchers have found that falciparum infections are increasing, particularly in East Africa, Nepal, and Colombia. And the Anopheles vector has been found at higher altitudes and latitudes. And a study from China found that for every degree increase in temperature is associated with somewhere between a 7 and a 13% increase in incidence of malaria. This is from a model which used the representative concentration pathways, or RCPs, which represent models for increases in temperature based on the concentration of greenhouse gases according to the IPCC. So as we move, where's the person? There it is. As we move from left to right, RCP2 is a fairly conservative and hopeful model for how climate change plays out, with RCP8 being one of the more worst case scenarios. And as we're moving here along the x-axis is projection moving into the future. And what we can see across most of Africa, they predict that there's going to be hundreds of millions of people who are going to be at increased risk of contracting malaria. But notably, as we can see in West Africa, the population that's going to be at risk is projected to decrease significantly over the next 50 and 60 years. And this is probably because the temperature increases in West Africa is going to make the area inhospitable for the Anopheles mosquito. These maps from the same researchers demonstrate how the length of malaria transmission season can change according to various RCPs by 2080. So orange and red on this map are associated with a longer transmission season, and teal and dark blue are associated with decreased transmission seasons. And so what we can see, to kind of go over the maps quickly, RCP 2.6, as a reminder, is a more conservative scenario, with RCP 8.5 being a more pessimistic. And all of these maps are for projections to the 2080s. And what we can see is in areas where malaria is already prevalent and in the tropics that are already hot, they actually project that there's going to be decreases in the transmission season, possibly because of increasing temperatures. But there's also a significant shift in the population that's going to be at risk, with significant increases in parts of southern Brazil and Central America, the Mediterranean, parts of Australia. And part of the reason this is so worrisome is as malaria enters a new population, it can cause a high level of mortality because it's going to be infecting largely non-immune populations. And the WHO predicts that a 2 to 3 degree increase in temperature is associated with an increase in risk for the increase in the population at risk for malaria of 3 to 5%, with millions more infections annually. So the West Nile virus, which is transmitted by the Culex mosquito and circulates between the mosquitoes and the birds, is also going to be very sensitive to climate change. So increased temperatures increase the growth rate of the Culex mosquito. It decreases the interval between blood meals. It reduces the extrinsic incubation period, which, as a reminder, is the amount of time it takes from acquisition of an infectious agent to being able to transmit that infectious agent. And it also directly increases viral transmission to birds. Warmer winters are associated with larger summer mosquito populations. And in contrast to malaria, West Nile virus epidemics can occur in times of drought, which is thought to be because drought brings mosquitoes and birds together at limited water sources and can enhance viral transmission, and also because the natural predators of the Culex mosquito also diminish in drought. There was a retrospective study from North America which found that an increase in mean temperature of 5 degrees Celsius was associated with a 30 to 50% higher chance of a West Nile virus infection, and higher temperatures have already been associated with prior epidemics in Europe. This is from a model for different cities in the United States for the number of weeks with mosquito activity for 2 different species of Culex mosquito. And so what we can see is, looking at different IPCC projections for climate change, so again, B1 being conservative, A2 being less conservative, generally speaking, across the board, they anticipate that there's going to be an increase in the number of weeks with Culex mosquito activity across the United States, but notably in areas that are already in the south and southwest, like Chandler Heights, Arizona here, and El Paso, Texas here, the rate of increase is less limited than in areas that are further north, like in Pennsylvania and in Connecticut. Dengue, which is transmitted by the Aedes mosquito, which is also the vector for chikungunya, Zika, and yellow fever, is also expected to have an increasing infectious disease burden, partly directly because warmer climates directly promote viral replication rate within the mosquito vector, but also indirectly because of an increase in projection of spread of the Aedes vector. So here on the right, we see a map of Europe and the Mediterranean region, and areas in red is where the mosquito vector Aedes is already prevalent, and areas in yellow are areas where it has subsequently spread to. And as we can see, the general tendency is for an increasing spread northward and up in altitude into some mountain ranges. Researchers in China have found similarly worrisome findings. So on the left is the projected dengue risk map based on the current temperature, and on the right is a projection which also used the representative concentration pathway 2.6, and it estimates that by 2050, the population at risk would increase from 172 million to 278 million by 2050. But if we can adhere to the RCP 2.6 the population at risk is expected to decrease slightly to 233 million by the end of the century. Alternatively, under the worst case scenario, the number of people at risk in China would increase from 192 million in 2020 to 328 million by 2050. And without appropriately addressing climate change, the number of people at risk in China can increase to nearly 500 million people by 2100. Plague, which is caused by the bacteria Yersinia pestis and transmitted by the Oriental rat flea, is considered an emerging infectious diseases. And its principal reservoir are wild rodents, mostly in Central Asia. And so this picture on the right is of the very appropriately named great gerbil, which serves as the primary host of the plague in Kazakhstan. And researchers found that there was an increase in risk of prevalence of greater than 50% for Yersinia pestis for every 1 degree increase in spring temperatures. And they found that the density of the reservoir population is the most important factor causing large-scale epizootics, which is an epidemic in an animal population. And the magnitude of these epizootics is expected to increase with climate change. And plague, I think, is a particularly concerning risk because it has multiple possible reservoirs, which makes it very difficult to eradicate. It can acquire antibiotic resistance plasmids under natural conditions in the flea, and when untreated, it has a 30 to 100% mortality rate. This diagram demonstrates how changes in climate can affect the risk for plague epizootics, which can subsequently increase the risk for human plague. So what we can see is increased precipitation can lead to both increased vegetation. It can promote the growth and survival of the rodent host, in addition to promoting the reproduction of its flea vector. High densities of rodents, increased flea survival, and cooler temperatures all increase the risk for epizootics, which can subsequently increase the risk for human plague. This paper modeled the shift in plague risk in the United States based on a variety of variables, including temperature, precipitation, and elevation. And the map in the top left is how they predicted the current geographic distribution of plague. And what they found is that they expect that it's going to shift northward and eastward away from the south and southwest, which reflects a temperature towards cooler areas experiencing warmer temperature and away from hotter areas that are getting hotter and drier. But unfortunately, data for this is more limited on a global scale. It's difficult to present on infectious disease nowadays without mentioning COVID-19. So I wanted to take this as an opportunity to reflect on our current pandemic. From the perspective of infectious pathogens, the major resource that is abundant, stable, and widespread is humanity. And as we continue to disrupt ecosystems, we increase the interface between humanity and neglected and new infectious diseases, which can promote spillover events. These researchers speculated that depletion of underground freshwater reserves to promote agriculture in China and Saudi Arabia may have been contributing factors to the development of SARS and MERS. These same researchers also found that the interval time between spillover events has been going down. So what they did here on the left, they assigned rabies to the year 1931, which is when it was isolated in bat brains. And on the y-axis is the number of years since the last viral spillover event. So as Marburg virus was isolated in 1967, 36 years after the onset of rabies, they were able to see that the number of years between the last bat viral spillover event has become shorter and shorter over the last century. Climate change is also having a direct impact on how we respond to COVID-19 and vice versa. So Atlantic hurricane season and Western wildfires are predicted to be worse than average in 2020, and the mass evacuation and sheltering associated with these events, like the image on the left of a mass shelter after Hurricane Harvey, will increase the risk of propagation of COVID-19. Additionally, extreme heat and humidity makes wearing a mask more uncomfortable and less palatable to a population that's already resistant to adopt their use and actively protesting their adoption, like the gentleman from the image on the right. Heat waves and other extreme weather events can contribute to surges in patients requiring hospital attention, which can strain already limited beds during a pandemic. That being said, I want to reflect on a prior climate-influenced pandemic, which I think can be instructive and is interesting. So the late antique ice age refers to a period in the mid-6th century, which was one of the coldest of the last 2,000 years. And this is because of several factors. So researchers found that you can recreate summer temperatures by measuring tree rings, and they've been able to use this to recreate the temperatures over the last 2,000 years. And what they found in the mid-6th century is that the temperatures dropped significantly, which is the red lines here on this graph, and this is the mid-6th century. And they suspect that this is because of several things. So there's evidence for massive volcanic eruptions that ejected a huge amount of aerosol into the air. There was lower than modern solar irradiance, and then there were also propagation via ocean and sea ice feedbacks. And so what this refers to is that as the planet got colder, there was more polar ice that collected and formed, which reflects more of the sun's energy back out into space, which leads to cooler temperatures, more ice, and more reflection, which it was a positive feedback system. And so consequently, the decade of 536 to 545 was the coldest in the last 2,000 years. And they refer to this time period as the Late Antique Little Ice Age, or LALIA. After the onset of the LALIA, there were widespread food shortages and famines across the Eastern Roman Empire. The shorter growing seasons forced the migration of steppe peoples and drove them into conflict with settled peoples, and cooler temperatures allowed the Oriental rat flea, the vector for Yersinia pestis, to survive along trade routes in the Sahara, the Indian Ocean, and the Red Sea, which had previously been inhospitable. So I want to return to this image before reviewing the coming storm. So before the rise of Rome, plague had no suitable rodent reservoir for plague. Rattus rattus, the black rat, which likely came either from South or Southeast Asia, colonized Europe somewhere between the 4th and 2nd century BCE and subsequently thrived in lands with a heavy Roman presence and quickly spread via trade routes throughout the empire. The dense population of Roman cities, like Rome itself or in Constantinople, contributed to a significant increase in the growth of the rat population, where they're able to feed on refuse and famously on grain. So we have multiple factors here conspiring against humanity. So one, we have increasing food sources, increasing rodent survival, increasing rodent density. But all of these things preceded the 6th century. It was only with the onset of the late antique Little Ice Age that the final piece of the puzzle arrived, the cooler temperatures which permitted the survival of the infected fleas. All of these things coincided during the reign of the Emperor Justinian and led to the first plague pandemic in world history, which we now refer to as the Plague of Justinian. So Egypt, which is over here, it was the predominant source of grain which fed the empire and sustained the high population of its cities, and it's where the plague first arrived in Pelusium in 540. It found its new host, the black rat, in very high numbers and was able to spread easily throughout the empire in the same ships which were meant to deliver the food to sustain its cities. The grain fleets, which carried food from Alexandria to Rome and Constantinople, had a significant role in the recurring outbreaks of plague. This is a quote from a contemporary who lived through the Plague of Justinian, and I would like to quote it here. Now, the disease in Byzantium, or modern Istanbul, ran a course of 4 months, and its greatest virulence lasted about 3. And at first, the deaths were a little more than the normal. Then the mortality rose still higher, and afterwards, the tale of dead reached 5,000 each day, and again, even came to 10,000, still more than that. And when it came about that all the tombs which had existed previously were filled with the dead, then they dug up all the places about the city, one after the other, laid the dead there, each one as he could, and departed. But later on, those who were making these trenches, no longer able to keep up with the number of the dying, mounted the towers and the fortifications of Psyche, and tearing off the roofs, threw the bodies there in complete disorder. And they piled them up just as one each happened to fall, and filled practically all the towers with corpses, and then covered them again with their roofs. So Procopius, who I just quoted, estimated that 100 million people died of the plague. And while this is certainly an exaggeration, it does reflect the incredibly high mortality and the profound impact it had on the people living during the epidemic. The Plague of Justinian arrived following a 26-year-long war between two ancient rivals, the Romans and the Persians, which had already exhausted both empires of both manpower and treasure, and it arrived before the advent of Islam in the mid-7th century, which resulted in the irrevocable contracture of the Eastern Roman Empire and the collapse of the Persian Empire. And lastly, the movement of pastoral people from the steppes may have contributed to the arrival of the Slavic people to the Balkans. So in conclusion, the fact that climate change is happening is undeniable, and we know that climate changes can have disastrous impacts on human health. As we've seen, many infectious diseases are expected to expand over the next decades, and our relationship with our environment may make pandemics like the ones we're living through more frequent. Previous infectious disease outbreaks have devastated prior civilizations, and as stewards of the public's health, I believe physicians have an obligation to act and advocate for changes that will mitigate our impact on the climate and the health consequences of climate change that have already happened. Thank you for listening, for those in the audience and those listening on Zoom. Appreciate it.
Thank you, Kevin and Megan, for those great talks. We'll move on now to the question and answer portion of the grand rounds this morning. The first question that I have is for Megan. So in differentiating between non-alcoholic and alcoholic steatohepatitis, is there an amount of alcohol that's allowed in order to make this differentiation?
Yeah, that's a great question. And currently it is 30 grams a day for men and 20 for women. So that's the cutoff we have right now. And that goes out to about 14 drinks a week for men and 7 drinks for women.
Okay, thank you for that. And then my next question here is for Kevin. So thank you for your talk. You definitely outlined several different infectious diseases which can worsen with the way that climate change is occurring today. I understand that as physicians, we do have a role to play in making sure that we do our role. Do you have any examples of organizations here in St. Louis or other activities that we can participate in, more so than writing to our legislators and advocating for the change that we would like?
My mentor, Dr. Matar, had mentioned that there are some resources for physicians who are going to be maybe going to private practice and can develop green clinics, or even here locally with Barnes. I think we need to ask ourselves, is Barnes doing everything that's possible to really reduce our impact on the environment? And I think all of these things on a local level, but then of course on a global level, are things we're going to have to deal with moving forward.
Great, thank you for the answers to those questions. We'll conclude grand rounds this morning. We're going to work on getting the QR codes up here to share with you all. Thank you for joining us again today.